Hi, this is the Cancer Patient Lab, and I'm Brad Power. And we're honored today to have Martin Lužbeták. Did I do that
Perfect.
right? Okay.
Absolutely awesome.
With us today to talk about his practice. I was introduced to Martin by Mark Taylor, who had a session. He's a very a role model for us of this being a super patient. Mark has many clinics around the world. Um, there we go. Mark has looked at many clinics around the world and different treatments and come up with some conclusions. And I'll recommend that you look at the session we had with him to get more background on that. But he's very much of a proponent of complementary therapies. And he's writing a book that will be hopefully coming out soon. And he introduced me to Martin. And Martin has two roles. He'll explain, but he has two roles. One as a doctor advising people in Vienna of a variety of treatments. And then he also has a lab in Germany, which he will explain how he ended up being the leader of that lab in order to guide patients in their care. Just the housekeeping things, we have three that we typically do at the front end here. The first is that this is for information purposes only. This is not medical advice. We provide information to patients so they can take it to their medical team. The second is that everything about this session today will be made public. So if you're concerned about protecting your image, turn off your screen or change your name or don't speak so that you can maintain your privacy. And finally, we are a patient-led community, all volunteer, and would appreciate any donations that people might make, which you can do through our website. So with that, I'll turn it over to Martin, and thank you very much again for taking the time with us. He's coming to us from Vienna today.
Yeah, good evening. Thank you for having me. Please tell me if you see my slide with my name big on it.
Yes.
Perfect, thank you. So I'm Martin Lužbeták. I'm a physician. I'm glad to be here. I love to talk to patients. That's why I still have a practice in Vienna where I'm practicing complementary medicine, and I have a lab. So I love the cells, I love the pathways, I love the genes. So I try to combine it, and it's not very easy. So to tell you where I'm coming from, who I am, maybe you imagine a quest for efficacy, because that's going to be through all my life. So I studied medicine. I started studying exactly 20 years ago in Slovakia. So, and my first thesis that or like a small seminary thesis I wrote was on TP53. So I immediately fell in love with molecular biology and molecular oncology. So through all my studies on the university, I was thinking I'm going to be an oncologist because I wanted to treat cancer patients. But on the end of it, I decided that I want to have more efficacy in treatment, so I tried to be a surgeon. So after the university, I started my career on a surgical unit in Germany because I spoke great German, I would say, very good German, much better than my English now. And I was working there for 4 years. And parallel to it, I started my Master of Science in Preventive Medicine, because I find out maybe prevention is even more efficacious in not preventing, but not treatment, but preventing disease. So this was my way out of surgery, and I started my internal board certification on a complementary oncology unit. So it was a hospital which had a station where we treated oncological patients with chemo and radiation, but we gave natural substances to it. That's the heart of complementary oncology, that you complement the standard care with something else, like selenium, vitamin D, omega-3 fatty acids, maybe multivitamins, probiotics, and so on. So I learned complementary oncology at its heart, and I'm deeply thankful for my former boss, Peter Holzhauer, oncologist like you never seen before, with his heart for the patients. And then I had to finish my board certification as a general practitioner, which opened my way into private practice, which I opened to 2018 in Vienna, because it's closer to Slovakia, where I come from. And I started to practicing there, and had a deep and very good cooperation with Professor Boyar, who had a lab for molecular oncology in Germany, in Düsseldorf. And he died, unfortunately, 2020. So I took over the lab, and since then I have two jobs. I care for my patients in Vienna, and I care for my lab, for my people in lab, and we do whole good diagnostics. So yeah, I try to be more effective, and now I have to double myself and be double the effective. And it's a awesome job, because I see the results from the lab and I can translate it into the care for my patients. So I immediately see if my efficacy is good or not good enough. And I have a great cooperation with other physicians, like-minded physicians in Germany and Austria, where we work, as to say, in a network of physicians who really try to live complementary medicine. So always the standard of care, if possible, plus the complementary therapies. And so I come to my second slide. So my question is always, what should I take? What should I give my patients? What therapy they should be given? And we have so many options today. 20 years it was not that much, but today we have a lot of chemos, a lot of biologicals, targeted therapies. We have chemo antibody conjugates. We have oncolytic viruses. We have so many advanced therapies. So for me as a physician, the biggest question is, how can I choose what my patients should get? And this is what we've been talking today about. For example, memorial slow catering. All the patients there with cancer get molecular diagnostics. So, I mean, this is a hospital we should look up to. And these questions, I go like this. This is my philosophy. What is the need of my patients? If they come to me and they say, I get chemotherapy and I want to know which natural substance or repurposed drug or other chemo I should take with it. Okay, and I say, good, this is our defined question. You get chemo with platinum, cisplatin or carboplatin, and you want to know if you should take curcumin or cannabidiol with it. Okay, we have to test it. So my questions are 20, 30, maybe 40 or 50 questions. This chemo with this natural substance, do they work together or not? Then I can take blood, because I isolate circulating tumor cells and try to find out if the chemo works. If the patient comes and he says, okay, my disease is very advanced and I just frankly don't know what I should do. And I said, yeah, I don't know it either. So we have to find out. And then we go for tissue-based diagnostic, because I can ask a tissue maybe 1,000 questions. If I do RNA or DNA diagnostics, I can go for whole transcriptoma, so look on the whole mRNA. I can go for exoma, so I can look for the whole coding DNA. So I can ask 20,000 questions, and then I distillate it to 1,000 questions that I take in an account where I have an option, and then we just do the diagnostics in a more broad way. So we don't ask specific questions. This chemo with this natural substances, yes or not? We ask thousands of questions, and we try to find out where are the sweet spots, where are the spots that are the cancer's weaknesses. And of course, if you know Sun Tzu, the great philosopher, he says, use your biggest weapon and attack on the weakest point of your opponent. And this is what we are doing. We are trying to find out the sweet spots. And we are lucky. In Germany, we have so many options on natural substances you can give intravenously. we have curcumin, resveratrol, spermidine, boswellia acid, dichloroacetate, 2-DG, 2-deoxyglucose. So we have many, many options we can give our patients. And with this sheer amount of possibilities, there is a need for diagnostics, I believe. Because I don't know what my patient's gonna need. I need to test it. So I try to base all my decisions on diagnostics. And then that's my quest for efficacy. If I have a good diagnostics, I have a good therapy, and I have good results. And that's medicine I'm living all day long, 7 days a week. So that's hopefully my short introduction. Maybe too short, I don't know.
And thank you, Martin, for that introduction. There's a question in the chat from Stratus, which I'll read to you. And everyone else, I think you know, raise your hand if you have questions. That's the other way, either through the chat or through the raised hand feature. But Stratus asks, tell us your view about dendritic and NK cell therapy in pediatric cancer and how we evaluate centers around the world that offer it, because the internet is full of ads and some legal, some scams. And I would just generalize this. I've heard this before, that in the domain of supplements, or you call them biologics and so on, complementary therapies generally, often there's a lower standard of evidence. So we have some evidence, it's evidence informed, someone said, not evidence-based. We don't have phase 3 randomized clinical trials with the combinations of all these things. And so we have to trust someone like yourself who has some science behind it, who does everything based on testing. So I guess the question generally is, how do you choose among the various people who are in your business of guiding people? What are the criteria you would recommend a patient or a caregiver would look at to select someone to give good advice in this area?
Yeah, it's a great question because I'm asking it myself all the time. My aim is to see the patients getting better. What should I do? And frankly said, you have to try. You send patients to different centers like me and see the results. And if the results are not good, okay, you don't send anymore. And then after years, that's how I began. And after years, I try to understand my colleagues, their weaknesses and their strongholds. So if I know my cooperation partner and I know he's exactly good at this point, okay, I send the patients there and I see the results. The patients come back and say, Dr. Lužbeták, thank you for sending me there. The physician is such a nice person and his therapy works. And I always need these two things. I love physicians that love their patients and try to be kind. And there are levels of kindness. Maybe you don't need a kinder surgeon, but I think you do. Even surgeons should be kind to their patients. And afterwards, okay, I do my diagnostics, I see what the patient needs, and I know where to send him. So it's an absolutely huge network where I need to know everybody's weaknesses and strongholds. So I have to say I'm not an expert in pediatric cancer. So I don't try to avoid these patients, but they just don't come to me, and I'm not good specialized in that. So this is my absolute weakness, and please don't send any pediatric patients to me. If they are maybe 14, 15, or like kind of getting adult, we can talk about it. But for a patient to find out which clinics are good or bad is so tough. So this is a very good question, because I think the patients have no chance to find out about all the clinics which on their own. The patients need their network, and this network of experience, and maybe some, you send some patients there and from your group, find out. So I'm absolutely behind this idea that the patients should talk together. Also, we talk to us, to the physicians, and we have to learn together. Even from my perspective, I love patients that are experts on their disease, because I consider cancer too complicated. So if you want to go to every detail of every patient all the time, you need really the patient who really can understand their disease, and colleagues that understand you. And in this network, we can really find solutions, because the sheer complexity of this is amazing.
Thank you for that. Just quickly, let me mention that in our discussion with Mark Taylor, he described an approach that he used to gather information from patients that went to clinics. And if you want to check out his website, Patient-Led Oncology, or look at the discussion that we had with him, he tried to solve the problem, or directly address the problem as Martin is describing it, which is gather experiences from patients who go to clinics, and what are they given, and does it work well for them?
Yes.
Stratus has a follow-up question. He says, thank you for the answer, Martin, but for some of the therapies, costs are over 30 to 40,000 euros, and the cost becomes too expensive to do trial and error for Europeans. What have been your experience about adding cost as part of the decision process for patients looking to find these sorts of treatments?
I'm lucky that I'm more than 10 years in this. So I know most of the very, very good German clinics. So I really gathered a lot of experience. And I always say my patients, just what's your budget? I know this is a question no physician likes to ask, because we don't sell anything. We helping people, and it's embarrassing to talk about money in Europe. Maybe it's different in States, but I always say this: you have to pay for your therapy. So define your budget, and we need to find a solution. And that's also a part of my job, to work on the repurposed drugs. So we really introduce agents that are low cost, bring efficacy, don't bring toxicity too much, and we can help all the patients. So, I mean, I understood this 10 years ago. We need to bring the change to the system. The system doesn't, the standard oncology is going its pace on very expensive medicines, and wants to go this way. And if we want something else, we need to bring it on our own. And we need to bring it with high evidence, because nobody gonna accept it.
Okay. Alan Morris asked a question in the chat. He said, you noted that there are thousands of questions. These are very complex decisions. That suggests that you must be using artificial intelligence. Do you? And if so, what AI? Yeah. So can you describe what your...
Sorry, I'm a physician. I have my technicians and IT guys and so on. They could give you the answer about the AI. I'm not into this. So if you have the question, write me an email. I can contact you with my guys. They can tell you. For me, it's I want to push the button and have the answer. In AI, I'm absolutely, I know nothing.
Okay.
I trust my technicians.
Okay. Next question. Brian McCluskey has his hand up.
Martin, thanks so much for coming here and discussing what you do. So, the Cancer Patient Lab was really formed in part to dive into advanced diagnostics, right? Because as patients, we're trying to redefine our cancer to identify targets of vulnerability. And the best way to do that is through advanced diagnostics. But, there's only so much tissue that patients have. There's only so much time that patients have. So if you look at sort of the universe of diagnostics, advanced diagnostics, what are the ones that patients should be focusing on that correlate to the most effective treatments?
If you have, if you need a short time turnover and you have defined questions, go for blood. If you have a lot of questions and a big problem, go for tissue. Always consider blood giving you less amount of answers to your questions than blood, from my perspective, what I've seen the last years. And I know every year there are coming more and more blood-based diagnostics, but the amount of information they can give you will always be less than the tissue, from my perspective.
So just to be more specific, though, right? I mean, should patients, insist on getting whole genome sequencing? Should they be doing proteomics? Should they be doing spatial phenotyping? Should they, what are the diagnostics that are going to help them to discern what are the supplements that they should be doing? I think it's a RGC that has all the testing, right? I mean, it's very comprehensive. So and patients just don't have that time, right? So what sort of guidance can you give to patients as they look at all of these different diagnostic options? Where should they really be focusing their time and energy?
So consider me as a one-to-one competitor with RGCC or some other providers. So when you ask me as a physician, I should turn off my lab half, and I can't. I'm just one person. So if you go for a caregiver and he works with a diagnostic tool and he says, this is what I've seen 100 times in a row bringing benefit to my patients, go for it, because he can apply the diagnostic tool and he gets the results back and he put it in life and it works in his patients. It's awesome. So in an ideal world, we would have the complete diagnostics in every patient. That's not cost effective, but ideal worlds doesn't exist. So my recommendation to the patients is you have a budget and you invest some of it into diagnostics and a lot of it you spare for your therapy. And this is where money comes into in a crucial decision way. Don't use too much money on your diagnostics because you're going to need it for your treatment. If you ask me what I use from my lab, I use all the variety which I have, and I always try to find out for this patient in this situation what he really needs, what's going to make a difference now. If I have a very bad situation and I need a really fast decision, I go for blood. I test chemo or some agents on the blood, and I introduce the agents, and when it works, okay, this is my lab, there should I stay. And this is how I came to Professor Boyer, my predecessor, because his diagnostics worked most of the times. The other labs didn't. And it's yeah, as you say, not every patient can try this. Try and error. You can't try all the labs. A lot of times patients come to me and have so many results for so many labs, and they are this way and that way, and nothing correlates. So you can get crazy from diagnostics. And me, it took me years and years and to find out.
Yeah, great. Okay, thank you.
Sorry for not being too specific. I don't want to do this as advertisements for my lab.
Yeah.
Chad, you had your hand up then. Didn't. Sorry, did that answer your question?
Yeah, Brian answered. Brian asked my question, but I will ask another one if it's okay. I used a lot of complementary therapies with chemotherapy. I used high-dose vitamin C. I used some heat therapy. I use fasting. Just curious if those are some of the other things that you recommend and how you do them. And then you had mentioned omegas, and I'm just kind of stumbling on some omega research and how they kind of soften some of the cancer cells. I was wondering if you could expand on when you had mentioned omegas.
Yes. So omegas are just amazing, but are an intervention. So you need the dosage, you need the diagnostics, you need the dosage, and you need to apply them right. So just wrap it up. If you have a lot of inflammation in your tumor, you can lower the inflammation with omegas, and your immunotherapy gonna work better. So this is a good concept, scientifically sound. And so I take blood. I look on the ratio of omega-3 and omega-6 in the membrane of erythrocytes. If it's not good, I supplement 1 gram or 2 gram EPA DHA a day. Maybe sometimes a little bit more, but I don't go very high on this supplementation. So measure, do, measure. I always apply this. In vitamin D, in selenium, in omega-3 acids, even I measure the microbiome in my patients. So that's why. And the first half of the question I forgot. Sorry.
I would just mention some other complementary therapies like high dose vitamin C, heat therapy, and fasting was kind of the 3 I did.
So fasting is absolutely awesome. 1 day prior to chemo and on chemo day and 1 day afterwards. If possible, if applicable, these 3 days are crucial for your fasting. This is something maybe I learned from Walter Longo, maybe from other therapists, from the Meyer physicians here in Austria, but I absolutely go for it if possible. Watch your body weight, but go for fasting. All my patients that became chemo without fasting and then afterwards with fasting never want to eat under chemo again. Never, not a single one of them. So if fasting is not working, most of the time it's in the head. So of course, fasting is a stress. So you need to be in the state of your mind that you would you would survive this stress. Yeah. So if you put too much stress on your system, it's never going to work because you overwhelm your regulation mechanisms. Vitamin C intravenously, I absolutely love that. Has, from my point of view, not enough evidence to say it's cancer killing, but it has absolutely amazing evidence for getting down the side effects of the chemo. I think it can have good effects on immunotherapy because your immune cells need vitamin C. And I'm not using it as much as I've used to, but I use it a lot. So fasting, vitamin C. If you want to know if the vitamin C is enhancing the effects of your chemo, I would try it in a lab first, and then I go for very, very high dosages of vitamin C in my patients. And the side effects are 0. Never seen nothing in thousands of infusions. So it's the toxicity that it brings is very, very low, but the efficacy could be a problem.
How do you test the vitamin C in the lab? So are you taking fresh tissue and then doing chemosensitivity with the vitamin C?
That would be absolutely the optimal situation. But you need a surgeon, you need transportation, you need to bring it alive in my lab. So it's a big hassle. So the patients say, you know what, I don't want to do this. I don't want to be having another biopsy and so on. So we go for blood. If we isolate circulating tumor cells, we apply it and it works. So you could have a good chance to have good results, and you would be disappointed how often it doesn't work at all. Yeah, so maybe if you go for very high dosages and give it like 3 times a week, you can reduce a lot of side effects of your chemo, and you don't gonna mess up the good effects, so the cytotoxic effects.
And you need intravenous, not oral vitamin C to make it work?
Absolutely no. I'm absolutely no fan of high dose vitamin C orally. Never seen work it. Never tried to really on a big amount of patients. If I have a common cold or influenza, or I should get sick and I have no other option, I take 4 grams vitamin C 3 times a day with my food, and it helps. but it's a single man study on common cold. So that's not cancer, and that's why I apply it in case of patients only intravenously.
Okay. Next up is Roger.
Okay, Doctor, I've got numerous questions, but let me just try to summarize a couple. I'm looking at your website and I notice you do CTC as well as cfDNA. And just a couple of things about that. Are both necessary? Is one better than the other? Is one more accurate? And are all CTC tests created equally? Because there are a lot of different companies doing them, and having done them from a lot of different companies, I get just wildly varying results.
Yeah, every lab has its different technique, and you consider CTCs as a multitude of subpopulations in your body, and they circulate into blood, into organs, into metastases, into the tumor, and then go around. And every one of the subpopulation have a different inner life, and you now measure it in this point of time once in the blood. Okay, so it's a picture, and on that minute, that hour, and you try to then isolate it from the blood and then count somehow. And all these steps are different in other labs. So if you measure it in different labs, you're gonna always have different results. And it's just because we humans have just this technology of watching the CTCs. So always consider you can't compare it, and it's only just the technique we apply on the blood. That's why some labs where you go and they take 8 hours blood from you and pick up the CTCs 8 hours long. Yeah, I think this is not applicable for huge public. Yeah, so because they want to have the CTCs in 8 hours, how many they come, because they recirculate from the reservoir, from bone marrow or from the liver into the blood and go up and down. So they are the CTCs are living cells you want to find in blood where they are not way too many, and you try to fish them out and count somehow, and this process is very complicated. And you see, this is how we humans try to measure living things. So it's a complicated thing. There are many books on it and many techniques. I think I try to measure CTCs and tumor markers, and if they go up and if they go down together, I hope I measure something which is reliable for my patients. So I mean, there are a lot of studies on CTCs, and I mean the consensus is they are prognostically valid. If they go up, the prognosis won't be good. If they go down or stay on the same level, the prognosis can be good. So this is what I would use CTCs for, and then we go take them out of the blood and test everything you want on them. Sometimes the substances work, sometimes not. I cannot test all the substances of the world.
Okay, thank you.
I answered the second half of the question again.
I think he's okay. I'll ask one question from the chat before I go to Rob, and that is from Alexander Lalov. What is the approximate cost of your most comprehensive tissue-based test and your blood-based test? So maybe give a sense of the prices.
So we do maybe now I know what I forget to answer. cfDNA and CTCs. Yeah, cfDNA is way too expensive from my perspective. I would measure it only in patients with known metastasis, with known druggable mutations, lung cancer, maybe breast cancer, where you really have a good chance that you find your mutations. So you don't want to spend 2,000 euros on something that brings absolutely nothing to you, you know? And this is going to happen in most of the time when you measure in other, like in sarcoma or melanoma. Yeah, you're going to find nothing in a small panel. In a huge panel, which brings a lot of costs, like from tissue. You can do whole exoma. It's like 6,000 or 7,000 euros. So it's super expensive. You can't do it all the time. And if you want to follow the evolution of your tumor, you kind of would have to. So the biggest panel we can do on tissue would be like 15,000 euros with transcriptoma, exoma, mutanoma, and so on. And on blood, we don't go too high. If you go the biggest panel for CTCs and the sensitivity, you will be 2,500 euros. So I try to keep the prices very low, I have to say. So I have to, I can really give this diagnostics to the most of the patients they would need it. And hopefully I help a lot of patients this way.
Okay. I'm going to tee up Rob Owen now, but Rob joined late, and the reason I sent him a text message saying you should join is because I know he has a great affinity. You had your third slide. You remember can you show the slide again where you had biologics and other teams? So it's a list of treatments that you had.
This is just a very small.
No, not that one. The one before
list.
this one. The one before.
Oh, sorry.
This one.
This is just a very small slide. These are not all the options.
Okay.
We have many more. This is a reduction for my slide because nobody could see if it would be too busy.
Okay.
But it's,
so I just want to use it as a
it.
setup because Rob had a similar slide for himself in his own treatment that had a list of possible treatments like this. And then he had on the other dimension, he had what are the methods of action? And then how are these different things affecting different methods of action, which is he's a chemist and an engineer. And so he reverse engineered. I just wanted to use this as a setup. And one of the key supplements that he's very keen on, because he recommended it for me, was zinc. And zinc isn't on this list, but I just wanted to use that as a setup. Rob, go ahead, please.
Thanks, Brad. Appreciate that. Pleasure to meet you, Doctor. Sorry I joined late. I got tied up in my office, and thank goodness Brad reminded me. Yeah, this is fascinating. I've been working. I was a stage 4 head and neck cancer patient last October. Modified my diet to just eating purely superfoods. Had a zinc supplement, which arrested the tumor growth on my stage 4 cancer. I went for 10 months without it growing. They took me off of it for a week. It grew 20% or more, and then I went back on it, and it arrested the growth. I was taking oral vitamin C daily, B12, and a multivitamin. Started by standard of care November 28th with radiation and cisplatin steroid combination. After 2 weeks, my tumor resolved. I ended my treatment after 3 weeks instead of going a full 7 weeks. Based on that information, I'd never had any ill effects from the treatment. Drove myself to all my treatments, never vomited. I actually looked younger, about 10 years younger during my treatment. I incorporated extra hydration, stick with my superfood, a very limited superfood diet, some moderate physical activity, dopamine release through getting outdoors. The foods that I was eating were helping dopamine release. I also took a prochlorperazine, which is a D2 antagonist, a receptor 2 antagonist, which is played a big role. So based on all this information, I built a matrix and reverse engineered how and why it all works so well. And I had a P53 gene mutation, so I isolated or focused on that. And working backwards, we've come to the determination that the zinc deficiency is what drove that mutation in the DNA strand. I'd had a high stress event, a long duration of stress, about a year before I was diagnosed, which I've worked back and actually been able to figure out that associated with a couple other things were the catalysts that drove the mutation to metastasize into my neck. So the questions are for you, how much work have you done on looking at zinc deficiencies? I believe The P53 gene is seen in more than 50% of cancers around the world. Zinc deficiencies are said to be roughly 15 to 20% of the population around the world are zinc deficient in their diet. Also with selenium deficiency, I noticed on the page that Brad put together that you do selenium. I noticed selenium deficiencies, genistein deficiencies with isoflavones are directly related to an awful lot of issues, especially with the DNA nucleotide synthesis during cell replication. If the resources aren't there, the DNA gets mapped incorrectly with the incorrect resources, creating a faulty DNA. Have you looked much into this, or how much do you know about this? And what are your thoughts?
I try to measure zinc and selenium in all my patients.
Mm-hmm.
I rarely find a huge zinc deficiency. Most of them are selenium deficient
Yes.
because in Europe we don't have so much selenium.
Mm-hmm.
So from my perspective, it's easier to get enough zinc from what we eat than than selenium.
Mm-hmm.
And I'm a huge fan of high dose selenium infusions in prevention of side effects of chemos and immunotherapies. So I really love them. Frankly said, I don't give zinc since years to my patients at all.
You should look into, especially with the effect that it has on the P53 mutation. I don't know how often you see that with your patients, but
That's the most found mutation in our patients. Like this is what I see a lot of times.
Okay. So the research I've done, and actually I believe there are human clinical trials going on currently with zinc supplementation. In vivo, they've identified that zinc arrests squamous cell carcinoma tumor growth. And I've based my work off that. I've actually written a peer-reviewed paper that we're getting ready to publish that identifies exactly how the P53 gene is missing a zinc ion. That's its mutation. So we've been able to identify it. Yes.
Rob, could you take it sounds like you should have a conversation offline because I want to get to a couple more questions.
I'm sorry. Yeah. So yes, I would love to. But it's good to hear that you're looking at these things. So the selenium, I agree with wholeheartedly. Thank you for your time.
Thank you. I'm going to read a chat from Ellen Miller. She said, I recently heard that high-dose vitamins could be counter-effective when pancreatic cancer is being treated with chemo. Do you agree that supplements aren't always an answer? And how can a patient find out what's the best route for their particular disease?
Yes, I never give something like out of blue and I think it's gonna help. So I always measure something and just put so many vitamins and so many supplements on it that you think there is no way it didn't work. Yeah, it won't. Yeah, so I think the amount of the interventions you can give and make is limited because your system cannot cope with hundreds of things. So if I have a deficiency, I go with a supplement. If I have a deficiency in a function of an immune cells, like NK cells, I go there in with a supplement. If I miss some cells, I'm gonna stimulate them. So the way I work is expensive, complicated, and I need so much time for every patient to consider so many things. And after years and years, I find out which works and less, and which works more. And I have to say, I still have a feeling that I'm just beginning. Every year I have my thoughts are, okay, we know absolutely nothing about what we do, and we still need to work more and harder and find better ways. And that's super hard because you're questioning all you do every day and try to make it better. And that's the only way how to fight cancer. And I learn from my patients, I learn from other therapists, and I have to say, hate physicians or therapists who do just only one sort of treatment for every patient that comes in, because for me that's not ethical way of doing things. Every patient needs something slightly different, or because his cancer type is different, his stage is different, his immune system is differently on, and so on. So the more diagnostics we can do, it would, I think it would make our work better.
Okay.
And you need to do it for every supplement, for everything you do. You need think why I'm doing this. For every supplement, every vitamin, every probiotics, for everything. That's how I work.
And let me just pick up a comment from Roger Royce. He said, and so it's kind of when you're doing this in a complementary sense, when it's, you know, you're maybe between treatments, but if you're getting chemotherapy. So he said, I was told by docs and by herbalists to avoid anything beyond a multivitamin when I was on chemo, because any antioxidant will fight the ROS aspects of the chemo.
No, that's absolutely wrong. And I mean, how can you say something completely wrong? Because you say don't take any antioxidants because, or you're running a risk of risking something. Yeah, it's based on what? Yeah, if you absolutely don't understand chemo, you have to be afraid of everything. Yes, but if you understand how chemo works and how chemo generates side effects, you can do what you really understand. If you understand the matter of chemo and the side effects, you can give it. I'm not a huge fan of multivitamins either. It's like putting everything in huge amounts and just hope something works. I always do single things if possible.
Okay. There are a lot of things in the chat. I'll try to get to more. There's a long message from HC about her cancer. It's a rare cancer, an ovarian cancer. There's no protocol for it at the moment. And she's worried about the frequency of testing after chemo. She describes the treatments she got, and then she said, I'm concerned about being screened after chemo and wanting to avoid recurrence. So I guess the question is really the testing you would recommend around chemo to measure effectiveness and recurrence.
Measure before and measure every 3 months, for example. Measurement, treatment, measurement. If you don't want to fly blind, you want to go where you're going, you want to know where you're going. So try to find out tumor markers working with you, test big panel, test CTCs, maybe cfDNA, try to find out what works for you. Maybe in the beginning you have to test more, afterwards you test less, but never flying blind. Every 3 months or so on, I would test at least the first 2-3 years, so to get some sense what's going on and go out of the risk area.
Yeah, we will be having future sessions on what's called MRD, minimum residual disease, and these are liquid biopsy or blood tests that monitor your disease progression after treatment. So this is very much consistent with what you're saying.
Yeah, this is my area.
Perfect. Then Helen follows up with, do you have oncologist colleagues in France who you would recommend using the metabolic approach?
Oh, no,
or
sorry,
complementary
no.
treatments? Okay.
Nothing come to my mind. I know Germany and Austria, but France, sorry.
Okay. Let me go to Chad, and then I'll cover as many more in the chat as I can before we finish at the hour. Chad?
Curious if you test for like chemo resistance factors, you know, such as like MDR1 or, you know, MPR or MRP, I mean, or any of those chemo resistance factors, and if there's anything you can do to, you know, help prolong the chemo.
Absolutely. I love that factors. That's not a simple question how to tackle them, but I mean, if you go and you see how they work and what's your possibilities, you always, when you do diagnostics, get a lot of results, lot of information, and you process it, and then again and then again, and try to find out how to tackle the resistances. I have to say the last years when I've seen how huge the resistances can get after couple of rounds of chemo, I just said, okay, maybe this is not the right way. Maybe we need not focus on the strength of the cancer, but we focus on their weakness, on his weaknesses, and attack there. So maybe a combined tactics with downregulation of multi-drug resistance and some immunotherapy or some other way, metabolic way around. So this comes to next concept of combination. I always combine a lot of methods. Okay, it creates chaos, but we have to do this because otherwise we have such a less efficacy.
Thank you. Is that okay, Chad? Yeah. I guess Helen was asking, my doctor won't redo the CT scan before 6 months. So it's a question, I guess, is how do you use scans in your, you've talked about liquid biopsy, you've talked about tissue sensitivity and so on. How are you using scans in your practice?
As often I can make them. Sometimes every month, sometimes every second month. I've never fly blind. I never trust nothing. I never use one single method. I go for CTCs, I go for tumor markers, I go for radiation. I always want to know what's going on. And if I have a slightly feeling it's not going my direction, I test. I go for MRI, I go for PET-CT every month. It doesn't matter, because if I fly blind and I fly to wrong destination, I just can't turn around. The time goes just one direction. If we miss the opportunity, we can't go back. And this big fear of testing and big fear of radiation and so on, I'm not in this club. I don't have fears. I just want to be as effective as I can, and as I have to, because this is a hard road. This is not the easy road with cancer. To beat cancer is hard.
Thank you very much. We're at the hour, so I think I will stop the recording.